Hello, welcome to the EKG Guy. If this is your first time, I'm glad you could join us this week. So this week we have a 47-year-old male with hypertension presenting with a sore throat. Here is his EKG shown below, okay, in front of you. On the side here, this is our approach that we'll use. We'll go through those here on the side. Okay, the regularity rate, where the rhythm's originating from, ventricular axis, how to find it, atrial conduction, AV or atrioventricular, IV and intraventricular conduction, different waveforms, are there any abnormalities there? And then is there anything else we're missing? We'll look at R wave progression as well as transitional zone in the precordial leads. So then as you complete those, give it your final interpretation, and we'll always compare it to a previous EKG that I'll make available to you. Alright, so pause the video, try to go through this yourself, try to get an interpretation. When you're ready, start the video and we'll go through this together. Alright, so hopefully you had a chance to go through it yourself. So here we have a 47-year-old male presenting with a sore throat. He has a history of hypertension. Okay, so the first thing we like to do here in making our interpretation is looking at the regularity, okay, the regularity of the rhythm. And we can use any interval, okay, that as long as it's consistent to find the regularity. The most common one that's used are finding R waves, okay, so if you look here at lead 2, and here's an R wave, and then looking at the R waves that follow suit, okay, those that come after. And are these R waves, so one R wave to the next is called an R to R interval. Are the R to R intervals consistent throughout? Okay, so if you were to measure these all till there, would they be the same? Okay, and those that follow suit, okay, are they the same? In general, actually, these are quite regular. Is quite a regular rhythm. Okay, the intervals tend to be quite consistent. If you were to measure these P waves, okay, that might be even easier to use. You would see that these P waves would be regular throughout. Okay, so overall, this is what we would call a regular rhythm. All right, you may notice already that some of those beats that come in the beginning here look different from those that come afterwards. Okay, maybe more clearly in this lead. So notice that they're different. So that's one thing to keep in mind. All right, we'll get to that in a little bit. All right, so this is a regular rhythm. Hopefully that makes sense. And we find that first because then it gives us a chance to, how are we going to find the rate of the rhythm? And that's the next step, okay? Because there's many ways we can find the rate, but knowing the regularity helps us guide which ways we can do it. Okay, one way that you could do it in both regular and irregular rhythms is by knowing that the beginning to the end of our standard 12-lead EKG, which is shown here, is 10 seconds in duration. So beginning to end is 10 seconds. So you're only getting a 10-second frame of the patient's electrical activity. Okay, so obviously you can miss some rhythms that come before and after it. Okay, so 10 seconds, and if you know 10 seconds times 6 is 60 seconds. Okay, and that's 1 minute. And what that tells us is if we count the complexes, whether it's all the P waves to find the atrial rate, or the QRS complexes or T waves to find the ventricular rate, and then multiply that number by 6, we can get an estimate of the rate in beats per minute. Okay, so in this case, let's find the ventricular rate. Okay, so we have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14. Okay, so you do 14 complexes. These are ventricular depolarization complexes times 6 is 84 beats per minute. Okay, so an estimate of 84 beats per minute. Okay, so that's one way you could do it. And then we said this is a regular rhythm. Okay, albeit there are complexes that look different, but in general, because it's a regular rhythm, there's another way I'll just show you how to do. Okay, that you can only use with regular rhythm. So that method we just saw where you multiply it by 6, that's with both irregular or regular rhythms. This other method that I'm going to show you is only for regular rhythms, okay? And so you find an R wave, so let's find this one here. Notice it falls on this thick line, okay? That's what you want to do. And then find the next R wave, which is this one here, to this point here, and count the number of those thick lines between it. So 1, 2, 3, between 3 and 4, okay? And you would do 300 over the number of thick lines, which we said was 3, is 100 beats per minute, okay? But it's really between 3 and 4, so you do 300 over 4 as well, which is 75 beats per minute. So the rate really falls between there, okay? And a little closer to the 4 end, that's why it'll be lower to the lower end, okay? So that's one way you could do it with regular rhythm. So you do 300 over the number of those thick lines, okay? The actual rate that the machine gave us was 85 beats per minute. Okay, so as you can see, pretty much close to what we got. So it's a good estimate of how we just found that. So that's the rate. So we have a regular rhythm, okay, generally regular, at a rate within normal limits in our adult patient, okay, about 85 beats per minute. Now we have to know, where is the rhythm actually originating from in the heart? Okay, so you have your heart. Where's the rhythm coming from? Well, we have narrow complexes, so narrow QRS complexes. These are within normal limits. Okay, so we know it's likely coming from a supraventricular source, not low in the ventricles. It's likely not coming from the AV node, okay, or a junctional rhythm, because we have every P wave preceding each QRS complex. Okay, so you have a P wave, QRS complex, a P wave, QRS complex. These coming after are T waves, okay? So you always have one P wave for every QRS complex, meaning it's probably an atrial rhythm. Now, because it's coming from the atria, then we have to say, okay, is it coming from the sinus node, or is it coming from an ectopic atrial source, okay? So normal sinus rhythm, we should know, is a high right atrial rhythm. What do I mean by that? So here's our heart, okay? So here's the right atrium, the left atrium, right ventricle, left ventricle. The sinus node sits up here, okay? From the sinus node, you have our internodal pathways that come to the AV node, his bundle, the right bundle branch, left bundle branch that subdivides into a left anterior and posterior fascicles. Then those branches go to the ventricular Purkinje fibers, to the cardiomyocytes, and so forth. Okay, and that's how it spreads. So our sinus node is up here, right? We said conduction will be heading in this direction. So now let's take this right atrium right here that we have, okay, and let's put it right here. So put our right atrium there. Here's our sinus node. Conduction's heading in this direction. So now we have to know the lead sitting there. Here's lead 1, lead AVF, okay. Lead 2 sits here at positive 60 degrees. AVR's here. In the horizontal plane, we have V4, V5, and V6. And I show you that because this is heading in that direction, so that means that these leads, okay, should have positive P waves. Okay, when we're looking for sinus rhythm, we're looking at the P waves. We don't care about the QRS complexes or T waves. We're focusing on the P waves. In AVR here, we should have negative P waves because it's heading away from that. All right, the impulse is heading away. So let's look at, we have that. So here's lead 1, upright P waves. Lead 2, the same thing. Okay, if we look at AVF down here, you see the same thing. Okay, if we look at the horizontal plane, V4, V5, and V6, you can see these upright P waves. And then if you look at AVR, you see these negative P waves. Okay, so in fact, we are dealing with a rhythm originating likely from the sinus node. Okay, so hopefully that makes sense. So that's sinus rhythm. Okay, not many people explain it this way, so that's why I want you to do it, because I think that makes the most sense. If you can understand why we're calling it sinus rhythm, okay, the whole idea of why the way I teach this way is because I want you to understand why we see what we see on the EKG. Okay, I think if you can do that, then you can start making sense of everything and why we interpret the way we do. Okay, so we have a regular rhythm at 84 or 85 beats per minute in sinus origin. Next, we want to look at the ventricular axis. Okay, so the P wave has an axis. Now there's also a ventricular axis in this case, and we're going to focus on the R wave or QRS axis. Okay, there's also a T wave axis, ST segment axis, but we're going to focus on the ventricular or R wave or QRS axis. Okay, and because we say that, we're going to be focusing on these big complexes. So normal ventricular axis in an adult lies between -30 and positive 110 degrees. Okay, so this is normal axis is here. This would be considered left axis deviation, right axis deviation, and northwest axis. Here's north, here's west, northwest. Hopefully that makes sense. So normal is in this range here. Okay, now we have to also put our leads here. So we said lead 1 sits here, lead AVF sits here. Okay, at positive 90 degrees is AVF, at 0 degrees is lead 1, the positive end. Okay, so if we look here at lead 1, you can see that our axis, okay, this is almost isoelectric, meaning that those above and those below are about the same. Okay, so hard to tell there. But if we keep looking through and look at AVF, the same thing, seems mostly positive. Okay, so you would think that positive or almost isoelectric in lead 1. Okay, so if it's isoelectric, it'll be heading on this direction, not towards or away from lead 1. Okay, so let me just erase that for you here. Okay, so not towards or away, but then we have AVF mostly positive, so heading in this direction. But I want you to notice that things above and below are occurring at the same time. So these complexes here are all occurring at the same time. And as we look through from left to right, notice that these first few complexes, which are all, okay, so let me just erase this so it makes sense. This is an important concept, and that's why I'm showing this EKG, because it's quite interesting, okay, what we have going on. So these first few complexes, okay, which means that are all occurring at the same time here, all right, are different. So this one is different than the ones that follow suit, okay, follow after it. So because of that, we are basing our ventricular axis based on these beats here, which are not the same as those that follow. So a way to kind of get around that is you kind of have to use the other leads. So we have to use lead 2, because lead 2 is the only limb lead that we have going beyond this, okay? And notice that in lead 2, these are mostly positive complexes. Lead 2 sits here, okay, the positive end, so the axis is heading likely in that direction, okay, within our normal limit of negative 30 and positive 110. So normal limits there. And then if we look at the horizontal plane, okay, which you don't typically do, but here's V5. Notice that V5 also has upright complexes, so in the horizontal plane. Okay, so this is more of a little advanced kind of axis interpretation, but this one is still within normal limits, okay, and it makes it hard because those first 6 beats that we saw, or 7 beats actually, are within those limb lead things, so you have to look a little bit beyond, okay. Now the axis here is normal, so we have a normal axis. The machine gave us 59 degrees, positive 59 degrees, and if you recall, lead 2 here sits at positive 60 degrees. Okay, I'd be wary about the machine's interpretation in the setting of these beats, but as you can see, this is still within normal limits. Next, we look at atrial conduction. In atrial conduction, we're looking at the P waves. Okay, is there atrial enlargement? So is there right or left atrial enlargement? Okay, so we focus on the P waves, and these ones are actually within normal limits. The best leads to look at are lead 2 and lead V1. Okay, and there's nothing here that would suggest that, no increase in amplitude or stretch of those P waves or duration that would cause that. So we won't get into all the details, but there is no atrial conduction here abnormalities. Okay, no right or left atrial enlargement. AV conduction, so this is when we're looking at the PR interval, okay, that makes up most of AV conduction, and the PR interval here was actually normal, okay, so no AV conduction problems. The PR interval that we found here, okay, that the machine gives us here, so here's the PR interval, was equal to 146 milliseconds. So I'll take that right from the machine, and as you know, in adults, the normal range is between 120 and 200 milliseconds, okay, or 3 to 5 small boxes, or one of the big boxes is the upper limit of normal. So normal here, no AV conduction abnormalities, okay. All right, next we want to look at ventricular conduction problems, okay? So IV means intraventricular, meaning within the ventricles, do we have any conduction delay, okay? So this is an interesting point here, so in this EKG. So the QRS duration that the machine gives us, which we look for ventricular delay, is actually, let me get it here, 104 milliseconds, okay? And normal ventricular conduction should be between 70 and 110 milliseconds, okay? So fair enough. So this is what the machine's giving us. But I want you to notice that we have these complexes here. These first 7 or so we mentioned are different from those that come after, okay? Especially in V1, all right? And this is something that we'll get to the next thing in waveforms. This is something you should notice is a RS-R prime pattern, okay? So an RS-R prime pattern, okay? So because of that, what we notice here, RS-R prime pattern, and this is in V1, okay? We also have these slurred S waves that are occurring here in these first 7 complexes in V5, okay? So slurred S waves in V5, okay? That's in our rhythm strips. But notice, if you look at V1 here, they're not present. These are all normal, okay? As you can see, they're normal down here. They're the same complexes that are occurring above and below. And then if you look at V5 here, you don't really see much of that. They're the same as those that are occurring down here. Okay? So without using the rhythm strip, you can see that you're missing what here is a right bundle branch block. Okay? In that case, it actually does look like this duration is somewhat prolonged. Okay? So it's hard to rely on the machine, and that's why I want you to not only be careful of what the machine gives you, as we saw with the axis, okay, as well as the QRS duration, which we won't comment too much on at this point, but also you have to be aware of looking at the rhythm strips, because if you didn't look at the rhythm strips, you would miss this incomplete right bundle branch block, or right bundle branch block that we see here, okay? We call that an intermittent right bundle branch block, okay? All right, so let's look. Is there anything else that we're missing? Okay, I think we hit on the main thing that I wanted to show you there. Okay, the next is R wave progression. Let's look at these last few things here. And these are in the precordial leads. So if you look here, remember our precordial leads are these leads over here on our standard 12 lead. Okay, V1 through V6. We're looking at R wave progression. So is the R wave, which is this one here, that first positive deflection, increasing in amplitude as we go from V1 all the way up to V5, okay? And actually it is, okay? It's not only increasing, but so how we consider normal R wave progression, okay, is either one, you have an increase in R wave amplitude from V1 to V5, or you have an increase in the R wave to S wave ratio from V1 to V5, okay? Meaning that the R waves progressively get bigger and the S waves are getting smaller, okay? So notice that the S waves are getting smaller. So we would consider that normal R wave progression here, okay? And lastly, let's touch on transitional zone. Now, transitional zone, if you don't remember, is when we go from having mostly negative complexes in our precordial leads to mostly positive complexes on the left lateral precordial lead. So from V1 to V6, we're looking for it going from mostly negative. So notice it's mostly negative, okay? If you look here, it almost looks like it's isoelectric, meaning this R wave is almost the same as that, okay? Maybe a little more negative, we'll say, but then clearly here, this becomes more positive, okay? Now, normal transition is between V3 and V4. This one seems to occur right between V2 and V3, okay? Because it's occurring before that V3 to V4 area, we call this an early transition, which is also considered a counterclockwise rotation, okay? So the same thing there. Now these last two things, I always mention that these depend on lead placement. So again, depends on who's putting leads on. This is a very imperfect science. So it can be helpful, but don't put too much reliance on them. Okay, but it can be helpful in times. All right, so that's that. So let's review. We have a regular rhythm at 85 beats per minute, sinus rhythm. Okay, what does that mean? That means we have a normal sinus rhythm. Okay, normal rate, normal rhythm, okay, sinus origin at a rate within 60 to 100 beats per minute. We have a normal axis, normal atrial conduction, normal AV conduction. IV conduction is pretty normal, but we do mention those beats early on, okay, that we said were consistent with an intermittent right bundle branch block. Okay, intermittent because it's occurring here, and then it goes back to its normal beat. So it's not always occurring. Remember, this is only 10 seconds of the patient's heart activity we're looking at. So normal sinus rhythm with a intermittent right bundle branch block. Okay, we said there's no ST segment elevation or depression that's significant that we should be aware of. Remember, these ST segment depressions and T-wave inversions are expected in normal in the setting of a right bundle branch block. Notice how it goes back to upright T-waves in the normal complexes. Okay, now if these were to be upright, these T-waves upright, in a setting of a right bundle branch block, that would be abnormal, and you'd want to think of ischemia or some pathologic condition. Okay, but discordance, in which the QRS complexes are going in one way and the T waves in the other way, in a right bundle branch block or left bundle branch block, are normal. Okay, so hopefully that makes sense. We said no PR elevation or depression, no abnormal Q waves that would suggest maybe a prior infarct. Okay, so when we compare this EKG to prior, what was seen on the prior was actually only normal sinus rhythm. Okay, there was none of that intermittent right bundle branch block. Okay, so this 47-year-old male with hypertension presenting with a sore throat, in this EKG, we may have just captured this intermittent right bundle branch block that we saw in those early 7 beats. Okay, and again, right bundle branch block alone is not often pathologic. Okay, so meaning that some people without even structural heart disease may have this, and we often don't do too much about it. Okay, so something to be aware of, often benign. Okay, likely the patient is presenting for something else, but there's nothing clearly abnormal here with the EKG. Okay, so this EKG shows normal sinus rhythm with intermittent right bundle branch block, and I thought it's quite neat that we were able to capture those first 4 beats, or first 7 beats, showing that. Okay, and what it does show the importance of is when we look for axis and everything, the importance of these rhythm strips down here at the bottom. Okay, keeping those all into consideration and not only focusing on these 3-second or 2.5-second strips right here. Okay, so the importance of the rhythm strip is very valuable here, and that's why I always want you to look at down them, and you'll notice sometimes that these complexes will change. Okay, so again, 47-year-old male with hypertension presenting with sore throat. His EKG shows normal sinus rhythm with an intermittent right bundle branch block pattern, and when compared to previous EKG, the only thing was it showed normal sinus rhythm. Okay, otherwise normal. Well, that's the end of this week's EKG of the week. I hope you learned something. Now I want to make you aware of our EKG coding reference that many of you are already using. How to get access, okay? So you want to go to this link here. So put in that link into into the computer, into your internet source, and then go to put your email address here when you get to that, and then you're going to use my password here to put in there. Make sure you're using my password every time, okay? And let me just erase here. So this one here, all lowercase, put that in, and then click submit. Confirm your email. So check your email, get a confirmation, and you'll have access, okay? And access here will be this, and you'll start to see that we have examples, and I'm now adding videos into it. So this is an on-the-go reference, has everything you could possibly imagine we use as we're building the course for our fellows here at Mayo Clinic, and so forth. So I think it's quite handy. Our techs are using it. We're using it for coding here as well. So very helpful way to learn, to use as a reference, and so forth. Okay, and you'll see a lot of the things we discussed in this lecture there as well. All right, so a few things. If you thought this was helpful, if you did, yes or no, I would like to know how I can improve, what kind of topics you want. Please leave them below. Like this video if you find this helpful, and share with friends. If you want more practice, okay, obviously more practice is on our Facebook page, where there's almost 500,000 of you there, and thank you for your support. We have daily questions, trying to get back to you between our clinics and making sure we're staying in touch. So go there for practice. There's daily practice. I leave resources. You can find us on Twitter, search the EKG Guy, YouTube, obviously, and Facebook. Okay, it's hard to keep up with all these things, so find us there. Share with your friends if you find this helpful, and please leave a comment if there's any topic or just kind words. We always appreciate it, and I hope you learned something today. Well, thank you for making us the largest, fastest growing EKG community in the world.